Good afternoon, everyone, and thanks for joining in. I'm Dr. Kim Newell Green, and I'll be the moderator for today's virtual Grand Rounds, sponsored by California Health and Human Services and the California Medical Association. The talk today is entitled Post-Acute COVID Syndrome, In It for the Long Haul. Please advance the slides. You can see here the disclosures from our speaker. Next slide, please. And this is our agenda. Next slide, please. As usual, we are able to offer continuing medical education. And just as a reminder, you'll be sent a survey after the completion of the webinar. Make sure to answer that so that you can attest to your attendance. And upon completion of that survey, we'll send out your certificates. Next slide, please. It has been a year of uncertainty as physicians, scientists, public health leaders, policymakers, and really all of us as citizens try to understand a newly evolved virus that is ravaging the world. Today, we're talking about sequelae of this virus that we're perhaps even more uncertain about. So uncertain that I don't know what to call it. Beginning last spring, patients and increasingly the healthcare community recognized that for many, COVID-19 infection doesn't end in the traditional 1 to 3 weeks of many viruses. The prolonged symptoms that have been attributed to SARS-CoV-2 have been called varyingly long-term COVID-19 recovery, post-acute COVID, subacute COVID, long COVID, PASC, which is post-acute sequelae of SARS-CoV-2. Experts dispute whether this is one syndrome or several, one manifestation being called myalgic encephalomyelitis / chronic fatigue syndrome, or MECFS. In a vacuum of information, patients who are suffering get active and push our thinking as clinicians and scientists. And often snake oil peddlers arrive. Today, we're excited to have two physicians from UCSF, Drs. Michael Peluso and Lakshmi Santosh, who will give us an overview of their perspectives on post-acute COVID and talk about their science-based research and clinical approaches to understanding and treating this new entity. As usual, we're also very grateful to hear an update from Dr. Erica Pan on the state of COVID-19 in California, including updates on our state's vaccination efforts. Following our presenters, we'll have our usual Q&A session, so please submit any questions you have by using the question box in the control panel located on the right-hand side of your screen. Now, I'd like to turn the time over to Drs. Peluso and Santosh. Dr. Michael Peluso is an infectious disease physician at UCSF whose previous clinical and research interests included HIV and global health, and where he's most recently been engaging in research and publishing around post-acute sequelae and recovery after COVID-19. And he's currently one of the co-PIs for the LIINC study. Dr. Lakshmi Santosh is an assistant professor of medicine at UCSF, where she specializes in pulmonary and critical care medicine with a focus on medical education. She's the founder and physician faculty lead of the multidisciplinary post-COVID optimal clinic at UCSF Health. Take it away, and thanks so much.
Thanks for having us today. We're excited to present to you. I'm going to be talking primarily about the key research questions and the research agenda for what I will refer to as post-acute sequelae of COVID, or PASC. And then Dr. Santosh will be talking about her clinical perspective and clinical management of this condition. Next slide, please. We don't have any disclosures. Next slide. So our objectives are that by the end of this talk, you should be able to discuss the different case definitions and epidemiology of PASC, discuss possible biological mechanisms that might underlie this condition, and discuss some of the treatment strategies for patients who are presenting with this condition with evidence from what is being done in the post-COVID clinics. Next slide. I'll begin by talking about some of the challenges really with regard to case definitions and epidemiology. Next. So as you all know, the scale of the SARS-CoV-2 pandemic is tremendous, and I think dwarfs what many of us would have expected a year ago. As of yesterday, there have been over 130 million cases worldwide, over 30 million cases in the US, and a really substantial number of people have unfortunately died from this infection. But importantly, many people have recovered or are recovering. And in fact, the vast majority of people who've previously been infected with this virus are in the recovery phase now. Something that we've noticed over the last year is the observation that not all COVID-19 recovery is the same. Next slide. So as you all know, COVID has multiple different organ system effects during the acute phase of the infection, and pretty much can involve any organ system and can present with a really wide array of symptoms. Next slide. And what we've seen over the last year is that just as there's tremendous variability during the acute phase of SARS-CoV-2 infection, there's also great variability during the recovery phase of COVID-19. And this schematic here shows some of the observations we've made both in the clinic and in the research center about people who are recovering from COVID. Many of these individuals experience a wide array of different symptoms. I've underlined the ones that have really stood out the most to me. This includes things like trouble concentrating, trouble with memory, fatigue, shortness of breath, and palpitations, often associated with exertional activity. But there are many other symptoms that are listed here that individuals can experience. There's a great deal of variability between patients in terms of what they experience during the recovery phase. There can also be variability within individuals with a sort of waxing and waning course. This happens in people who were hospitalized, but it also occurs in people who were not hospitalized, who constitute the vast majority of people recovering from COVID. And importantly, in some early studies, it's been shown to be associated with a decrease in quality of life. Next slide. So we used to really focus in on what is in red here, acute COVID-19, and we're trying to move as many people as possible into the recovery kind of bucket. But now we know that many people can experience a post-acute illness and late sequelae indicated here in blue, which is really the topic of this talk. So the key point here is that for many people, COVID is not just a 10 to 14-day illness. And there have been many efforts at UCSF and at universities across the country to try to understand what's going on. I wanted to specifically call out Lakshmi's effort, the Optimal Clinic, which is providing post-COVID care to individuals, and also a study of pregnant women and their newborns at UCSF called Priority, which has really informed management of pregnant individuals with COVID. Next slide. So a key caveat here is that the symptoms that individuals experience don't necessarily equate to objective measures of organ dysfunction. Sometimes they do, but symptoms can occur without evidence of organ dysfunction, or evidence of organ dysfunction can occur without symptoms, or they can co-occur. And so this is something that's really kind of complex and we're trying to parse out. Next slide. So I'm going to outline 5 key questions regarding the research and clinical agenda for PASC. And the first is, how should this condition be defined? Currently, there's no universally accepted case definition, and a lot of people are working on this. I think some of the key questions are outlined here. So what symptoms should be included? Is somebody who is experiencing fatigue and cognitive issues the same as somebody who has only GI issues or only cardiopulmonary issues? Are there different phenotypes? Do we need to think about patients in sort of different groups? The second question is, what signs or objective findings should be included? So are symptoms alone sufficient for the case definition? Are objective findings necessary? What do we do if somebody has an abnormal echocardiogram but no symptoms? So that's a big challenge. And then the third question is, on what timescale are we talking here? So if somebody is symptomatic at 3 weeks, is that really to be unexpected? Most people, I think, will still get better at that point. What if they're still symptomatic at 3 months? We don't really know what the trajectory is yet. Next slide. So as many of you will know, reports of post-acute symptoms in both individuals who had been hospitalized and those who had not been hospitalized emerged really within the first couple of months of the pandemic These are some popular media headlines from late April, early May of 2020. Next slide. And more recently, these observations have made their way into the scientific literature. And so I'm showing two studies here. The top study is a UK study from their Office of National Statistics that came out just last week, using what they called a population-based survey and data from the NHS. And they calculated that 13.7% of individuals with COVID experienced symptoms beyond 12 weeks. And then the bottom study is a Nature Medicine paper from about a month ago that was using an app-based study, again, mostly participants from the UK and the US, looking at 4,000 incident cases of COVID in individuals who had no prior problems. And they also found a small, but I think significant proportion of individuals with persistent symptoms. Next slide. So our study is called LIINC, which stands for long-term impact of infection with novel coronavirus. And we're trying to delve into these issues. So we enroll individuals who have PCR confirmed COVID and are entering the recovery phase. So they were sick more than 14 days ago. And we follow them closely for 4 months and then quarterly for up to 2 years. And we work closely with a couple of studies of acute infection. So we kind of have the full spectrum of clinical data and biological specimens on a subset of people. We've enrolled over 300 people over the last year, and about half of them have this condition called PASC or long COVID. And we're working to really try to understand what underlies this now. Next slide, please. These are some data from our study looking out to 8 months in the cohort. And so you can see here there are 34 different symptoms on the y-axis and 4 time buckets going across. And I think the key is really the last 2 columns at 4 months and 8 months following infection. What you can see is that there are a wide array of symptoms that are reported by our participants. These are symptoms that are new since they had COVID, no pre-existing symptoms. And there are some that really stand out, like fatigue, respiratory problems, neurologic problems. And so we're working hard now to understand what predicts these symptoms and what biological processes might cause them. Next slide. I mentioned impact on quality of life. And so this is a busy slide, but the key information is in red at the bottom, which is that at these late recovery time points, our participants report that their self-rated health is slightly lower than it was before COVID. A difference of 5 points is not a huge absolute difference, but on the scale of COVID, it could be quite important. Next slide. And then we also find that there are significant symptoms of anxiety, depression, and post-traumatic stress in the cohort. These don't necessarily associate with persistent physical symptoms, but they're also there, and we're working to understand those relationships. Next slide. So there is evidence of organ system dysfunction in late recovery. The top study here is a neuro study that was based out of our cohort, looking at persistent neurocognitive symptoms, and we're working with Joanna Helmuth, who's a neurologist, to understand these symptoms better. The second study is a study out of Wuhan that was published in the Lancet in January, showing persistent pulmonary abnormalities in a lot of people who had recovered from COVID. And now we're working to understand pulmonary recovery as well. And the third study is a cardiology study in which cardiac MRIs were performed at about 2 months, found a significant burden of cardiac fibrosis, and we're investigating this as well in LIINC. And so there are a lot of efforts now underway to really characterize this condition. Next slide, please. So the key point here is that there's really no agreed upon definition yet, and there may actually be several different phenotypes of PASC, and that's something that's going to be important to understand over the next few months. Next slide. The second key question that everybody wants to know is how common is this condition? If you look at the literature, the prevalence has ranged from 2% to 90%. That is quite a wide range. And the reason for this, I think, is that almost every study that I have read does not have a representative sample. And so this includes our study. It's possible that people who are not feeling well are motivated to enroll in or participate in these studies, and so they could be overrepresented. It's also possible that there's a subset of people who are feeling so unwell that they can't imagine participating in a research study and are underrepresented. And so it's really hard to say right now that anybody knows just how common this is. But I think the key point is that even if it is uncommon, say less than 5% of people who have COVID develop PASC, the sheer numbers are problematic. 5% of 30 million is 1.5 million people in the US. That's a huge number. And so it's a problem that I think is increasingly hard to ignore from a public health perspective. Next slide. The third key question is who gets PASC? So determining who may develop PASC can guide both our clinical care and our research efforts. These are the two studies that I spoke about previously, and they identified some potential predictors of this condition. So they found that increasing age, but not beyond age 70, was associated with this, increasing BMI, female sex, having more symptomatic acute infection, having a pre-existing condition that limited one's activity, and also lower socioeconomic status, which I think is really important because we know, especially in California, that the pandemic has been disproportionately concentrated in communities of color and communities with less resources. And so this could be a major problem for those communities as well. Ultimately, predictors of clinical symptoms, objective findings, and the trajectory of symptoms will all need to be identified. Next slide. I'll talk a little bit now about the biology of PASC. Next, please. So this is a schematic that one of our medical students made for us, asking, what is the biology that could underlie this condition? Because that's really going to be the key to understanding what's happening and developing interventions to prevent or treat it. So it's pretty well established now that during acute infection, the virus is really widespread in the tissues. It's been pretty much identified in every organ compartment I can think of. And it's possible that there is some persistence of viral genetic material or viral protein or antigen beyond the acute phase, beyond the infectious phase of COVID. That doesn't mean that it's viable replicating infectious virus, but there could still be antigen there. Or it could be a hit and run type thing where the virus comes, causes damage, initiates some sort of cascade and then is gone. Regardless of which of those processes are at play, I think there are 4 key mechanisms that could underlie this condition, which are in the middle panel here. So the first is systemic inflammation, and I'll show a little bit of data about that. The second is local tissue inflammation, so not systemic, but in the tissues with immune cell infiltration into the tissues. The third is microvascular dysfunction, which we know is quite a problem during acute COVID. And may persist into the recovery phase. And the third is autoimmunity, which has gotten a lot of attention lately. Ultimately, we think that one or more of these 4 mechanisms could be driving the organ system pathology and ultimately the clinical signs and symptoms that individuals are experiencing. And studies like ours are well positioned to answer these questions because of all of the biological specimens that we've collected. Next slide. So I'm just going to run through quickly some data to support what I just said. I won't go into a lot of detail on these studies, but I've listed the citations. So the first is a study that was in Nature a few months ago, where they identified persistent viral antigen in the gut of individuals who had recovered from COVID 6 months ago. This was a small number of individuals, but I think it generates some interesting hypotheses about potential underlying mechanisms. Next slide. It's well known that there's a lot of immune dysregulation during acute COVID, and different immune signatures have been identified during the acute phase. Next slide. This is a study of convalescent plasma donors, so people who are donating plasma who are feeling better, and it showed that there are significant elevations in markers of systemic inflammation, even in people who are feeling well after having recovered from COVID. Next slide. And then there's some early data that's all in preprint form involving autoimmunity, suggesting that autoantibodies are present both during acute disease and may be present during the recovery phase, including in individuals who have persistent symptoms. Next slide. So the NIH has allocated $1 billion to study this problem, and many groups are writing grants to try to access this funding to be able to design and implement well thought out studies to answer these questions about the mechanism. Next slide. And then finally, to introduce Dr. Santhosh's portion, I'll just talk briefly about the key management questions. Next slide. So, I think there are three key questions here. The first is that we are now in a new era of COVID prevention and treatment with vaccines and monoclonals available, and we don't know yet whether these interventions will change how common PASC is. The second is that we need to identify certain interventions to help people manage their symptoms, even if we don't understand the underlying biology yet. And the third is, do certain interventions actually treat this condition and cause it to resolve? And to understand whether that's the case, we really need interventional studies that can intervene upon the underlying biology. So now I'll hand it over to Lakshmi to talk about clinical management.
Thank you so much, Dr. Peluso, for that great talk. So I'm going to talk about how are you managing this patient in front of you who tells you, I have long COVID, I have symptoms that are persisting after COVID. What can you do? That will be the focus of my presentation. First and foremost, I wanted to highlight that there are many studies suggesting that the disparities that we know, as Dr. Peluso mentioned, COVID is a disease that we've seen has devastated our communities of color particularly, and we have to be very aware that these disparities can continue in the post-acute era as well. So there are things such as predisposing conditions, conditions increasing the outcome risk, post-disease conditions affecting long-term outcomes, and things like access to care that we all have to be very deliberate and thoughtful about thinking about to ensure equity in our care for our communities with COVID-19. Next slide, please. So you may be wondering, so what do the guidelines tell me to do about the patient in front of me? Sadly, there aren't too much to report, so I'll tell you what is known so far. The British Medical Journal actually has this very good infographic of guidelines, and you'll see here, I've listed the reference at below, they really focus on how there's a lot of uncertainty. I think Dr. Peluso highlighted multiple of the areas of research uncertainty, and similarly, there are so many areas of clinical uncertainty. What we do know now, you need a full history, talk to patients about their current symptoms, the trajectory, manage their comorbidities, and also layer upon that social, financial, and cultural support throughout. Next slide, please. And one of the things that they emphasize is medical management of symptoms as well as self-management of symptoms. I really like these guidelines because they emphasize things that patients can do when you counsel them, like use a home pulse oximetry so that when you're exercising, being aware of what are safe O2 sats and what are not. Pay attention to the basics of diet, sleep, quitting smoking, limiting alcohol and caffeine intake. You'll see they specifically recommend self-pacing and gradual exercise increase only if tolerated. We'll talk more later about how there are similarities, as Dr. Newell mentioned, between chronic fatigue syndrome and some subset of post-COVID patients. And so this guidance on really pacing, rest, and very gradual aerobic exercise is key. They talk about things like using a multidisciplinary team and paying close attention to mental health management as well. Next slide, please. How long do you follow patients after? We heard the statistics from Dr. Peluso about how long symptoms may persist. And the short answer is not a lot is known. Our clinic initially, when we started in May 2020, said that prospectively we would follow patients 3 months sequentially after their acute infection. So post-hospitalization, at the 3-month mark, at the 6-month mark, at the 9-month mark, we quickly saw that some people needed to be seen more frequently, and some people could actually be discharged back to primary care after the first visit. So this was an article laid out by Dr. Ragu and colleagues laying out this roughly Q3-month timeline. But we've seen in the real world, a couple months later after the dust has settled, that it really is individualized. And I think that we started prospectively planning an outcome of looking at clinic patients like this, but now we've learned to be more flexible and adaptable to what the patients need. Next slide, please. What about the American Thoracic Society? Some American recommendations for guidelines. The American Thoracic Society and the European Respiratory Journal put together a task force looking at evidence about post-acute COVID-19, and they also found that there are really more research questions than there are answers out there. They said that a lot is still uncertain. We don't even know how often we need to do things like a 6-minute walk test, PFTs, chest CT, a TTE, or even routine screening of cognitive function, depression, and other mental health metrics. Next slide. We don't know about how long to continue anticoagulation if patients are on them as an inpatient. We don't know about serological testing to assess those inflammatory markers. And we don't even know if there's good data for multidisciplinary clinics like ours in the long term. So all of these questions still need to be addressed. That being said, I'm going to tell you what we've learned experientially so far. Next slide, please. So I'm going to take you about one of my patients, Miss L. She was an 83-year-old woman. She spoke Spanish primarily, and she was recently discharged from our ICU where I'm currently attending right now. I met her in the ICU. She suffered from type 2 diabetes, hypertension, and hearing loss, and her daughter was her designated power of attorney whom she lived with. During hospitalization, she was on high flow nasal cannula, very high flows, fortunately didn't require intubation, and was discharged first to a subacute facility, then a SNF, and then ultimately home, but remained several weeks later breathless, anxious, and socially isolated. So I'll tell you about what we did when we saw her in clinic. Next slide, please. Our clinic is the Multidisciplinary Optimal Clinic, and we started in May of 2020. We're a multidisciplinary center. We have specialists from pulmonary, geriatrics, psychiatry, integrative medicine, as well as key clinical faculty champions in cardiology, neurology, and others. We try as much as possible to integrate with many of the amazing research efforts. We send Dr. Peluso our patients all the time to participate in the LIINC study. And like I said, we tried to see patients early on about every 3 months, but that's a bit more flexible now. We focus primarily on folks who have been hospitalized either to the ICU or to the ward. And we acknowledge that that's just the tip of the iceberg, that the majority of patients with persistent symptoms, the majority of patients at all, have not been hospitalized. However, because of the limited resources of the multidisciplinary team, some of whom were literally volunteering their time, they had to draw a line somewhere. And so based on our partnerships, their multidisciplinary team members, we said for now, our scope is to focus primarily on hospitalized patients. However, we do see people who have persistent dyspnea, persistent chest pain all the time in our general pulmonary clinic as well. So both of these are options to you. Next slide, please. We've seen over 300 patients so far, and our racial, ethnic, and sex, gender, demographic data match pretty closely to those hospitalized in the UCSF Medical Center system. So we're a little bit more male predominant than female predominant, a little bit of an older population, a heavy patient population with multiple comorbidities such as different organ transplants and other disease states. And we have a mix of patients who are white, Black, Latinx, Asian, and other races and ethnicities. We are a member of Cairo, which is a post-ICU clinic collaborative that's national. Many of those post-ICU clinics at Cairo have actually pivoted to post-COVID, and so we're learning a lot from our national partners as well. Next slide. We've published about our experience and how to set up a clinic like ours in CHEST, which gives kind of a practical how-to guide up to what EPIC templates do we use, what are our referral pathways. So if you're interested in some of the nitty-gritty, please check out our publication in CHEST. Next slide. What we do is we use a post-intensive care syndrome framework, not because all of our patients are from the ICU, but because this is a really holistic, deliberate framework that has a lot of evidence that's actually very applicable to the post-COVID-19 population. We systematically look at people's function in 4 domains: pulmonary function, physical function, cognitive function, and mental health. And we also pay special attention to the caregivers as well. Next slide. Like I mentioned, we have a hub and spoke model. So we have a couple of core clinicians who will see the patient at the first visit, the pulmonologist, the psychiatrist, the pharmacist, and then based on people's needs, we'll then refer them to our dedicated faculty champions in the other clinics through expedited pathways. We also have robust peer support with peer support groups. We try to link to pulmonary rehab, and we encourage close linkages to primary care. So our goal is not to supplant or replace primary care, but to work in close tandem with them and to really provide a great experience for the patient in their recovery. Next slide. What I do recommend is using, if you are starting a clinic like this, using core outcomes that have been validated and measured. So these are the core outcome measures that are recommended by the Improved Long-Term Outcomes Respiratory Failure Group. However, I'll point out that our clinic doesn't exactly use these outcomes because some of these questionnaires are proprietary, and so you have to go with whatever is cheapest or covered by your center sometimes. I'll point out some key similarities and differences. Next slide. So what we do is we have trained mental health research assistants who talk to patients and administer structured questionnaires for depression, anxiety, breathlessness, PTSD, physical functioning. We also talk about the social determinants of health. We do a lot of emphasis on MedRec. I can't tell you how many times I've seen patients on inappropriately prolonged steroid tapers, anticoagulation that's about to run out literally tomorrow. So the pharmacy is a key component of our clinic. We do a lot of counseling about safe physical activity, a lot of reassurance, expectation setting, knowing about what the research shows so far, when people can get back to their normal lives, and link people to resources in our community. Next slide. The persistent pulmonary issues that Dr. Peluso talked about, as he said, a lot of this research is very challenging. What I've seen personally in clinic is that there is a huge spectrum. You have some people with a relatively normal CT afterwards, like in slide number B, whereas you have some people with persistent ground glass afterwards, like in slide number C. I will say that I've had people who have been prone, paralyzed, on death's door, and I've been surprised at how afterwards they may have very little residual effects with pretty close to complete healing. However, other patients have persistent pulmonary symptoms. Other patients have persistent pulmonary fibrosis. There really is just a huge spectrum. And I think one of the key questions that Dr. Peluso and his team are working out is to define that spectrum and to figure out if there are subphenotypes so we can figure out how to best help these patients. And also the other question is compared to what? We don't often have good control groups in these studies. Say this CT study, this looks at patients recovering from COVID-19 and hospitalization, the Huang study as mentioned, but there wasn't necessarily a matched control group of people who were admitted for sepsis to another cause. So it's really tricky to know how to prognosticate or predict for some of these patients. Next slide. Advance, please. This study from ERJ also shows, as Dr. Peluso mentioned, that symptoms don't always correlate with organ dysfunction and vice versa. So this study showed that chest radiography did not actually predict respiratory symptoms nor functional impairment very well. Advance, please. Instead, patients actually also had high symptom clusters with fatigue and breathlessness and sleeplessness often tracking together. So that is why a multidisciplinary approach is really essential for these complex symptoms like breathlessness particularly. Next slide. What can we learn from the post-ARDS literature? That teaches us from this study and others like it that people can have persistent functional abnormalities, pulmonary abnormalities for months to even up to 2 years afterwards. In this classic New England Journal article, folks' diffusion capacity on their PFTs remained abnormal for up to 2 years after. Next slide. What do we do to navigate this mess here? How do we approach diagnostics? We do recommend pulmonary function tests for people with persistent symptoms about 3 months after the visit. 1 month after hospitalization, we often counsel and reassure people to say, this is going to get better. Let's see if you're still symptomatic. And if they're still symptomatic in our next visit, then we do pursue PFTs with the 6-minute walk to see if there's desaturation. Often the 6-minute walk is also helpful because you can look for exertional tachycardia as well. And oftentimes people don't desat, but they experience that either orthostasis, dysautonomia, or exertional tachycardia that can be perceived as fatigue, chest pain, and breathlessness as well. So the 6-minute walk is a really key diagnostic to help disentangle. If the DLCO is low, then only we pursue CT chest imaging. We do an echo if people have had underlying comorbidities or if their diffusion is abnormal or if they have significant parenchymal abnormalities in their chest CT. And then for labs, we often will just do the basics. CBC with diff, oftentimes because again, that fatigue can be from anemia as well. So we want to make sure that's not the cause. ESR and CRP, as they say here, just show that the lab is open. They're often non-specific. When we've checked them, we've not found them to be clinically helpful. Thyroid studies, helpful in a generalized workup for fatigue, so I often will send it for that, but not specifically for all comers. And CK can be helpful for people with a lot of myalgias with fatigue, just to see if there's anything elevated there or not. Next slide. This study, again, pre-COVID from ARDS survivors also showed that 2/3 of ARDS survivors reported significant fatigue symptoms up to a year after discharge. Again, we acknowledge that a lot of the post-COVID population has similarities and differences to the post-ARDS population. And a lot of the post-COVID population has significant severe fatigue without having been hospitalized at all. Next slide. So what do? We seek to guidance from experts, from our physical therapy colleagues. They published this really helpful manifesto. Next slide. This shows this concept that I use with patients all the time. I show them this graphic and I talk about this is the concept of pacing and rest and paced exertion, that you really want to adapt to an increased load. And instead of going up and up and up, walk 5 minutes, 10 minutes, 15 minutes, 20 minutes, you see a much more gradual paced exertion and recovery, and emphasizing rest if people feel like there's setbacks. This is a really different model from our traditional counseling of just gradual aerobic exercise, go up and up and up. Next slide. We've talked a lot with Dr. Peluso about the research into the neuro and psychiatric symptoms, and there are multiple possible mechanisms as he outlined. Next slide. We know now from this study just published in the Lancet a couple of weeks ago that as many as 1 in 3 can have either neuro or psychiatric symptoms, ranging from things like strokes to neuropathy to mood disorders, anxiety disorders, and even memory issues mimicking dementia in some cases. So Dr. Helmut's study will be key in figuring out and disentangling all these symptoms and figuring out the underlying biology. Next slide. We also know, again, from the post-ARDS literature that cognitive issues, cognitive impairment, depression, and disability are heavily intertwined. So a holistic approach is really important, and also asking patients about their illness experience, asking them about their social support, about their financial support, how are they doing? Many folks are unemployed now, are on disability, to figure out how we can support patients holistically in their mind, body, and whole functioning. Next slide. We also know that COVID is a delirium factory, as leading delirium researcher Dr. Wes Eli put it. You add an infectious pathogen, doctors and nurses coming in full PPE, a language barrier, people who are intubated and sedated for weeks. And so rates of delirium are incredibly high, and the recovery from delirium can be quite long, on the order of weeks to months as well. Next slide. So we do a lot of deliberate counseling and expectation setting about mental health. We talk deliberately about social isolation and loneliness. We talk about peer support. We go through with people their hospitalization and their ICU course and validate that experience, listen to them, remember with them, sit with them as they process these memories and talk about them. And we have standardized after visit instructions to help provide them resources about coping with all of these. Next slide. One last key point that I'll leave you with is that all that long hauls is not COVID-19. I personally, in our clinic, have diagnosed metastatic lung cancer, sarcoidosis, hot tub pneumonitis, hyperthyroidism, postpartum depression, just to name a few, in patients who either the patients themselves or their physicians labeled them as having long COVID. So please, please keep a broad mind. Avoid anchoring bias and work up new problems, particularly new symptoms that come up, with a broad open mind, because all that long hauls is not COVID. This is such a prevalent disease, unfortunately, that different true and unrelated things are going to pop up. So avoid that anchoring bias and listen well, think holistically about the patient in front of you. Next slide. So returning back to our patient to close out during our visit, we talked to her, we counseled her and her daughter about her recovery. We recommended gradual aerobic exercise with a home pulse ox. We talked about inhalers. We had integrated mental health support, which made her feel a lot better. And we provided reassurance and linked her to a couple of resources and sent her to follow up with us in 3 months. Next slide. So our take-home points for Dr. Peluso and I's talk today. We've seen that COVID has multiple organs that are affected both acutely and chronically. Dr. Peluso's research and others is trying to investigate the biological basis of PASC. And really, for treatment, a comprehensive multidisciplinary approach is really important to address disability, fatigue, and the neuropsych symptoms. And a lot of uncertainty remains and a lot of research has yet to be done about next best steps. Next slide. Thank you so much for listening. Here are our 2 email addresses and my Twitter handle. And we also have the link to the LIINC study here for your patients who are appropriate to enroll in that. Thank you for your time.
Thank you so much, Dr. Peluso and Dr. Santosh. Amazing amount of work you are doing. It's clearly a team effort and it needs one. And it's really nice to have that solid information in the face of what we're reading in the media, which often is really skimming the surface. We're going to hear from now from Dr. Erica Pan, our a frequent guest and the California State epidemiologist and a deputy director at the California Department of Public Health. Welcome back, Erica. It's so great to see you. We're always so grateful for any time that we get for you. And then we'll bring Drs. Peluso and Santosh back on towards the end. So take it away, Erica.
Great, thank you. Can you hear me okay? I'll
Yes.
assume yes. Okay, great. Thanks for having me, and good afternoon, everyone. And really helpful and interesting to hear about what's going on right here in the Bay Area. I'll just launch in. Next slide, please. So I just wanted to kind of briefly cover a smattering of things. As the state epidemiologist, I can give you an update on our epi and how we see things statewide right now. Some updates on variants, which obviously are kind of one of our hottest topics right now and what we're watching closely, where we are with vaccine coverage and updates, and obviously there's some hot off the press news I'll touch on briefly. And then it'll be great to have a connection after this that we're starting to think about kind of our CDPH activities with long-term COVID. So it'll be great to connect with other partners in the state who are doing this great work. Next slide, please. So this is just a snapshot of our dashboard, kind of just to give an overview of where we are. So we are at 3.6 million cases, and our case rate, we look at that as a daily rate, is down to 4.7 new cases per 100,000 per day. So this is one of the lowest we've been over the course of the pandemic, which is actually great news. And there was a rapid decrease after the winter surge and somewhat of a plateauing lately. So we're watching some sort of leveling off, but it does seem to be currently pretty stable. Deaths are continuing to decline, and as most of you know, are very much a lagging indicator. And then testing wise, we are seeing less testing, but still more than we saw during kind of the nadir last fall in between our surges. And what's really great to see is that despite even lower numbers of testing, we are maintaining a less than 2% test positivity. So it's been 1.5% for the last couple of days as well. And really thrilled to say, actually, even breaking news since this last update, we have hit over 23 million doses administered in California to date. Next slide. This is just our epi curve, just kind of, again, to show you kind of over the course of the last 15 months where we've been. Again, the huge winter surge and the decline I mentioned and kind of the plateauing now, but thankfully, again, seeing the steady plateau. Next slide. And then here's what's happening across the country and what we're watching very closely. So I am sure most of you have been hearing about what's been happening in Michigan, some of the other sort of Midwest and Northeast, that they are seeing increases in surges again. We've been hearing that Michigan is actually getting to the point where they are postponing some elective procedures again in some of their hospital systems. Largely what they are seeing, which I'll show in a few slides, is B117 UK variant. But you can see we're doing quite well in California, at least currently. And we did see a trend, I think, historically as well, as far as a lot of the sort of waves kind of working their way from the east towards the west during the fall. But we didn't have vaccines as our tool then. So we're really hoping that we can stay ahead of this with vaccines. Although again, these other states are doing pretty similarly as far as their vaccine coverage. Next slide. So on that note, though, I think what may be different about what we're seeing here in California compared to the Midwest is we have our, what many of you have been seeing and hearing. We've been trying from the California Department of Health to call it the West Coast variant, not the California variant, but admittedly the media and others are calling the variant we've seen a lot of here the California variant. And there's two flavors of it. You'll see at the bottom here of this graph, B1429 and B1427. They're very similar. They are distinct, but have two some of the same mutations that we were about on the spike protein, and they are really predominant across the state of what we've been seeing. So we're up to, you know, as you can see here, about 65-ish, 67% of the specimens we're sequencing are of this California or West Coast variant. So they are very dominant in what we're seeing. And then you can see here, this blue line is our increase of B117. So it had been much lower kind of, you know, in the late 2020. It was about, you know, 4% in January of what we'd sequenced, and 2% in January, and really inching up, and now we're getting closer to 9 or 10% of the specimens we've sequenced in March. So starting to be concerned about that increase in those. But again, our large dominant variant here is the West Coast variant, which, you know, our early data on that as well shows that it might have some increased transmissibility compared to the prior sort of more original strains of this virus, but less transmissible than B117 or the South African variant or the Brazilian P1 variant. Next slide, please. And here, just want to show you the great progress we've made as far as sequencing and how we have an increasing network of laboratories that are doing sequencing in California. So you can see, and of course, a lot of this is a lot of catch up. So it is not as real time as we'd like, and we're working on that as well. But you can see in January, which was at the end of sort of our surge, we were only sequencing less than 1% of our isolates, but now we are up to over 7% of our isolates are being sequenced as far as total numbers, and then just again the percent of our isolates. So we're and continuing to work on having more sort of strategic surveillance strategies to make sure we have a good geographic spread as well as severity. Next slide. So what are they seeing in the Midwest? Next slide again. So in Michigan, Minnesota, and Wisconsin, and I want to give credit to a colleague in the Minnesota Department of Health who just presented this to the state EPIs yesterday, but what they have been seeing is this recent increase here in end of March, early April. So Michigan is the one we've been hearing the most about, and you can see this steep rate of rise here. Minnesota looks like they're kind of close behind, and then Wisconsin is starting to see maybe some inklings of an increase as well. And in Minnesota, they're of what they've sequenced, it looks like about 60% of their recent cases are actually B117. So, you know, not sure if our West Coast variant is somehow has some survival advantage over B117, and again is less transmissible as we kind of have our race of vaccines versus variants, but that's one hypothesis that's out there. But again, we're watching this closely. As you saw, our B117s are increasing. Next slide. So, so that's the variants, and then how are we doing in our vaccine side of the race? So again, I mentioned, you know, already over 23 million doses administered. Happy to say that over 27% of the eligible individuals 16 of age and over are fully vaccinated. And then of our 65 and over, we are at 56% that are fully vaccinated, and well over 70% who've had at least one dose. And I think as far as you can see on this left side of the dashboard, and we'll be updating and improving this dashboard very soon, but we are at about getting close to half of eligible individuals having had at least one dose in California. Next slide. And this is just a nice kind of illustration of how we have ramped up over time. So as we've gotten more supply, we have been able to ramp up. Next slide. And then how are we doing on equity? So this is an area, as you know, we met a couple benchmarks. We had declared we wanted to hit 2 million doses in our Healthy Places Index quartile for persons in the least healthy community conditions. And then we hit a 4 million. So this is actually looking more at the people and proportions of partially vaccinated versus fully vaccinated. So you can see we still have some disparities here. And then I think the next slide, and this is on our dashboard if you want to look at a deeper dive, and this is also on our dashboard, but we have made some progress here. So you can see early on in January where we were and how we are closing this gap. We still definitely have work to do to, you know, this is getting only close to equality, and we're not even at equality. What we really want is equity, which is, you know, 40% I believe Dr. Peluso just mentioned this as well. We know there's a disproportionate burden of disease in our quartile 1, and we estimate about 40% of our cases, hospitalizations, and deaths are in that quartile 1. So what we really need to do is get vaccination to be approximately 40% of our population. So we are doing a lot of efforts in partnership with local providers, local health departments to improve our delivery of vaccine to quartile 1 and quartile 2 as well. So you can continue to watch this, and we'll have some updates on our dashboard very soon with other ways at looking at our progress on health equity and vaccine administration, including by race ethnicity. We're kind of working right now and refining that data, validating it, making sure that we are again, able to do some validation with our local partners and making sure it actually is as cleaned up as possible to be as accurate as possible. Next slide. And then I think you all know this, and actually in a couple more days, we will have every Californian 16 years of age or older will be eligible for vaccine. So I want to continue to make sure that we message that doesn't mean we have enough vaccine for every Californian 16 of age or older, but absolutely, want to make sure, as we've seen certain parts of the state move through the eligible populations, and wanting to make sure we're continuing to vaccinate people, that we are able to open that up. So again, in a couple days, and many jurisdictions have already started, especially again in that quartile 1, which is our biggest focus, to vaccinate persons 16 years of age and older. Next slide. So also, I know many people have been waiting patiently, and the CDC has already put out guidance about, and this can hopefully incentivize people to get vaccinated. What can fully vaccinated people do? What is our public health guidance around this? So similar to what the CDC's put out, we are about to post our guidance around fully vaccinated people. So if people are fully vaccinated, they can visit private households of others who are fully vaccinated indoors without wearing masks or physical distancing. And then this one is really important, and I know has been important for our family as well, as far as grandparents. So, and having children that are not eligible yet to be vaccinated without a vaccine that's been approved. But fully vaccinated people can visit with unvaccinated people from another single household who are at low risk for severe COVID-19 disease. And again, this is really largely, I think, people who are low risk, especially our children who are not yet eligible. This is kind of the license for grandparents to come in and hug their grandchildren, which I've seen lots of great photos, and has been so wonderful to see our kids finally get to see their grandparents and have some indoor time. And then finally, we're also saying that if people are fully vaccinated, if they have a known exposure, especially if it's, a sort of minimal exposure or not as significant as a close household contact, no need to quarantine if fully vaccinated. Next slide. So the other thing that we're posting today is kind of what we're calling our capacity bonuses. So again, we're really hoping a lot of these things help incentivize people to vaccinate. So many of you know, we've been gradually updating our blueprint sectors with what's allowed in each of these color tiers. And we had already put in the outdoor venues for outdoor sports, for example, that if everyone was tested or vaccinated, that the capacity could be even larger than kind of the baseline of what we'd allowed. And we're posting some additional allowances for this, so that in the orange tier, if certain indoor venues, if everyone can show proof of testing negative or fully vaccinated, that a venue can increase their capacity by up to 50% to a maximum of 50% of the capacity in the orange tier. And then similarly in the yellow tier, venues can increase their capacity by an additional 50% up to a maximum of 75%. So this is going to impact actually places like movie theaters, gyms, places like that, where they can increase a teeny bit. We still want to make sure we are messaging, and we hope all of you do along with us, that anytime you're taking your mask off indoors is still risky. So, but if people are again fully vaccinated or have tested negative within the last basically 72 hours, there's some nuances to that we can allow for an increased numbers to be in a specific setting. And the other thing in this updated guidance will be that, sort of along the lines of what I just presented about fully vaccinated persons in general being able to be indoors and unmasked, then in more public venues, if there are fully vaccinated nights or hours or sections that people don't have to physically distance if they're all showing verification of vaccination. Next slide. So what is acceptable as far as vaccine verification? So right now in these early stages, it's really showing your CDC card or a photo of your card, which can either be sort of on your phone or another device, or an actual hard copy photo, or if you had gotten your vaccination at a healthcare provider, you can show documentation that way. There are, of course, a lot of conversations happening both at the federal level and here at the state level, and a lot of apps that are being sort of developed around vaccine verification, and some of which may include test verification as well. We'll be working again alongside in parallel with the federal government on what are some of those standards and guidelines. So actively in discussion about that. And we'll be including kind of, I think really important to us as a state is we want to continue to incentivize vaccines, but also make sure we are approaching this with equity and ethics in mind. So we are including bioethicists in our discussions around this as well. But again, as we're already seeing sort of more empty clinic slots, we really want to do everything we can to incentivize getting people vaccinated to get us through this pandemic. Next slide. So with that in mind, again, hot off the presses this morning, I'm sure most of you know by now, but the CDC and FDA did issue a statement this morning with a pause for the Johnson & Johnson vaccine, and we also issued a statement soon after that to pause, and we'll be coordinating closely with the federal government on this and looking to our federal authorities. Just to briefly kind of highlight of what we know so far, that in the 6.8 million doses or so that have been administered here in the US, there have been 6 reported cases of blood clots. So cerebral venous sinus thrombosis, there have been a couple, I think, splanchnic or GI clots as well. And the thought is that it's due to thrombocytopenia and potentially some kind of a TTP similar to what had been seen with the AstraZeneca vaccine in other countries. So both of these, just to remind people, are adenovirus vaccines, as opposed to Pfizer and Moderna, which are mRNA vaccines. So they do have a similar mechanism. So, again, pressing pause. And the most important thing for all of you to know as clinicians, and an early part of this statement from CDC and FDA, and the CDC also sent out a health provider alert that hopefully all of you got as well, is that if you do see a patient who has some symptoms that are concerning for a clot who has been vaccinated within the last couple of weeks, typically you might be considering using heparin, but actually that could be dangerous if there's also a risk of autoimmune heparin antibodies. So really other alternate treatments, including things like immunoglobulin, are to be considered. So that's actually the other key message, especially to all of you as clinicians, to keep in mind. And again, these 6 incidents that have been reported so far all happened within 13 days after vaccination. They were all women, all between the ages of 18 and 48. So the ACIP subcommittee is having a meeting today, and we have 3 members of our Western State Scientific Safety Review Group. Actually, next slide might talk about this as well. Actually, this is something else, but just to continue on the Johnson & Johnson for a moment, there's a subcommittee meeting today, and then our Western States group will meet briefly. And again, we have an overlap of 3 members on our California and Western States group that are sitting on that ACIP subcommittee. And then tomorrow, the ACIP is doing a more public meeting to really review the data that we have so far and make some recommendations. And then we'll have our California and Western States group meet tomorrow evening to review what is publicly available about the situation and help provide further information and recommendations for what we should be doing about Johnson & Johnson vaccine. And then just because this is also a hot topic, wanted to let you know we are getting lots of messages from some of you directly or indirectly as well about delaying second doses. We did actually convene just last Thursday our Western State Scientific Safety Review work group to discuss the issue of delaying second doses. We have done some modeling and projection data based on what we know about projections of supply. This was before knowing what's just been announced today about the Johnson & Johnson pause. Right now, if we delayed second doses by 2 weeks, which would still be within the current CDC kind of allowances, it would only actually accelerate our vaccine coverage by about a week. And then we also did some looking at modeling to see if there was very high uptake and some moderate NPIs and current vaccine coverage, it would potentially help decrease cases, but it would still be lower than our summer 2020 surge. And some of the modeling really had to assume very high uptake, like up to 90% uptake of vaccine. So that group has actually discussed the most recent data and evidence. They discussed some of the pros and cons of a potential different timeline, also along with implementation and communication issues and the current levels of transmission here in California. And at least for now, the scientific safety work group has recommended not to increase the interval to second doses. So they have made that recommendation to us as the state administration, and we are reviewing their recommendations in our modeling and still under further review and consideration. But just wanted to let you know we're actively thinking through modeling, projecting, and discussing this, but currently no changes in our recommendations about intervals right now. Next slide. And then the other kind of really good news that came recently is that Pfizer has applied, as many of you hopefully know, to request an amendment to their use of the Pfizer vaccine to expand its use in 12 to 15-year-olds. They had recently released their data on their initial trials in 12 to 15-year-olds. So we're waiting to hear how quickly the FDA will be reviewing and considering that application, but there was good efficacy that was demonstrated and good vaccine safety and tolerance there. So we're anticipating, hoping that there will be some expanded authorization to vaccinate 12 to 15-year-olds in the very near future, and certainly before the fall. Next slide. And then, the topic of the day for all of you, I think we are just now really starting to think about what are our options at the State Health Department for kind of working with our surveillance database and developing a COVID-19 registry of long-term outcomes. So we would love to collaborate to do this longitudinal follow-up on long-term symptoms and other impacts. So I'll definitely be following up with the others on this grand rounds today, where again, we're just kind of starting to think through this, but really wanting to invest some resources into this in the long term and really looking at, what are these long-term impacts that can inform policy and program interventions and provide recommendations on long-term recovery. So again, looking forward to collaborate with others around this and to keep Californians updated on any progress on that as well. Next slide. And this is just, just some summary of key resources from us as far as vaccine administration, the call center for providers. We've been just briefing them this morning on, responses to J&J, the J&J situation. We are also, just on that note, creating a webpage specifically for ongoing updates from us or federal authorities on updates on the Johnson & Johnson situation. So you can look to our immunization website for our website with postings on that. So we'll keep you updated as we can. And next slide, I think that may be it. All right, I will pause there. Thank you.
Thank you, Dr. Pan. As always, it's just such a treat for us to get the inside view on what's going on in the state from you. Michael and Lakshmi, if you can pop back on, we'll begin some questions. I will start with one for you, Erica. So every month when we have people sign up for this speaker series, we get questions from our registrants. And I was struck that the first question this month was a simple 3-word question: how much longer? So I know that we're all feeling bottled up, frustrated.
Uh-oh, is she frozen for everyone else too? Yeah.
And impatience. But first of all, Erica, you sort of alluded to these projections on getting to some level of vaccination herd immunity. Can you publicly, but can you tell us publicly what projections are on when we're going to get some sense of whatever herd immunity is in this disease in the state?
Such a great question, and as always, never kind of a straightforward answer, but I will tell you what we do know and kind of how we're thinking about it. So the other thing that we are updating I can't remember if it's every 2 weeks or how often, but on our website, we've also been showing, and I didn't show you all today, but happy to the next time I come on, our seroprevalence data. So we have gotten close to 40% of seroprevalence in the state, and I think that is a 4-week average looking at blood bank data as well as any reported antibody data that gets us as from the state. So obviously the people getting proactive antibody testing probably have a higher sort of seroprevalence just based on any clinical reasons they're getting their antibody tested, but then the blood bank data helps us, and we look at the weighting of that. So we think about 40% of Californians have antibody, and of course varies by region, and that also the regional variation is on our website. And then, as I mentioned, we're getting close to half of our population, at least 16 years of age and older, who have had at least one dose. What the overlap is, of course, is harder to know. I think some of our projections show that we should be able to get, if we continue to have good uptake, supply-wise, we should be able to get to 75% of eligible Californians by the end of May or early June. Again, that really is banking on really good uptake. So that's where I really look to a lot of you in the audience to really continue with us to have good messaging. And actually another time, we're happy to share some of our latest campaigns and some of the data on the focus groups that have been happening around vaccine hesitancy and really working on that. So, but that is sort of how, you know, I think you do know that the governor has announced June 15th as a date that we would potentially retire the blueprint and be able to move forward. And the caveats to that are that, again, that our vaccine supply stays good and that we, you know, I think from the public health perspective, we absolutely want to make sure we have good vaccine uptake as well. And also that we continue to have great trends as far as our, not only our cases, but specifically our hospitalizations. So that is what's been concerning as well in Michigan, that they're really actually to the point of considering postponing elective procedures and things like that, because I think our hope is that we vaccinate a lot of our most vulnerable who would be hospitalized, and that if we're not overburdening our hospital system, some of the things we've looked at are, you know, how much, what's in a bad flu season, what are our hospitalizations looking like, and also looking at kind of annual deaths from flu versus COVID-19, and if we can get to a level that, you know, obviously we all want to prevent as many deaths as possible, but we have tolerated other vaccine preventable diseases over time. So those are all in the projection, and, you know, we hope that in a couple months that we will be there if we keep these trends. I'm very nervous about what's happening in the Midwest, and I just heard Oregon is seeing a surge as well. So we really need to also keep up the messaging about continuing to mask, continuing to physical distance until we can get more people vaccinated.
Thank you. I turned off my camera because of the usual internet difficulties we all have intermittently, so, but I am here. Michael and Lakshmi, I'd just like to turn to you quickly. A lot of our, the people listening are curious about what other centers they can refer patients to. And I'm just wondering how much you know about other centers within California. We're asking resources within Southern California or within Kaiser. Are you working with folks who are in the other parts of the state around this post-acute COVID sequelae?
I'm happy to take that first. So yes, since the beginning of the pandemic, it was a different time, it was a different administration, and there was not a lot of coordination at the federal level about the long-term sequelae of COVID. So informally, a group of us across California, as well as across the nation, have pooled our experiences for our post-COVID clinics. I mentioned the Cairo Collaborative as one place to look. In terms of post-COVID specific centers, I've worked with colleagues at UCSD, Cedars-Sinai, and UCLA, where they have centers up and running, including multidisciplinary support, connections with pulmonary rehab as well. Next month, we're going to have a summit hosted by the California Thoracic Society for people who are current leaders of post-COVID clinics across California, as well as people who are interested in learning more about the experience of the clinic leaders from post-COVID clinics across California. So that's going to be coming up in the month of May as well. We've also been doing some advocacy with some of our Congress representatives about getting better care coordination across California and across the country to better, more prospectively track, to build organized networks and collaboratives. And right now, often the patients themselves know where to go. So patient support groups and their websites often have a patient curated list of who are the clinics, who are the main providers. I found my name on some of those websites and colleagues as well. And so I think that will be an important priority, I think, for our state and our federal infrastructure to delineate clearly to patients sort of these are recognized centers of excellence, people who are closely working on clinical and research efforts together. But the short answer is UCSF, UCLA, Cedars-Sinai, UCSD. I've been in talks with folks from Kaiser. I think because of some of the challenges of the payment model and it's the fact that it's already an integrated payment structure, they feel that there's not a need to actually put all the services under a one-stop shopping in my chat with them, but they offer similar services, just not necessarily one-stop.
That is such a useful list. Thank you. It sounds like there's lots being done. And Michael, how about on the research side? I read in December that at that time someone looked and there were only 45 long COVID projects underway worldwide out of 5,000 plus total COVID research projects. That was years ago in COVID time. Are you feeling like the studies on this are ramping up fast enough? Of course, never, but how's that looking?
Yeah, so the NIH convened its first workshop on this topic the first week of December of 2020. And so groups like ours had kind of been trying to sound the alarms for some time, and obviously the patient advocacy groups were quite vocal as well. And I think that workshop really kind of lit a fire, so to speak. And so as I mentioned in February, the NIH announced that they were going to make a major investment in trying to understand COVID sequelae, and basically released a call for applications with like a 3-week turnaround. So many people applied for those, but the goal of that effort is to really create a national network that can gather enough cases from a really diverse population to try to understand a lot of the questions that I was asking about. And so, that's happening, which is great.
Great, thank you. Erica, I'm going to turn back to you for this one. You've alluded to it, but we saw how the B117 in California has really decreased compared to these West Coast variants, and you showed us that great data from Minnesota that shows really B117 is predominant there, but there was no data from Michigan, and I'm curious about what's happening on the East Coast. I've read, I think that New York and other states on the East Coast, they're seeing surges now. I do have high prevalence of B117. So I just wonder if you have any data on Michigan and the East Coast on that particular strain and thoughts about maybe why it's surging there and not here. You sort of alluded to the fact that maybe this West Coast one is somehow protective, or that's not the right word. But anyway, this is all speculation, but tell me anything you can.
Yeah, the CDC is also continuing to evolve their data on their website. And so I do believe that both sort of, yeah, so I think Michigan is also seeing more B117. I haven't relooked at some of those other states that were sort of those dark hotspots. But in general, yes, I think a lot of what's being seen as far as these newer surges is predominantly B117. And yeah, it's very speculative and just hypotheses, but what we do know is that our West Coast variant is, and there was a great household transmission study by, actually other UCSF colleagues looking at household transmission, and it does seem to be, maybe slightly more infectious, but not dramatically like B117. So maybe more in the 20% range as opposed to, 50. I've seen up to 70% for B117, and it has been very dominant here. So, and you saw those graphs. So I think that it could be a reason, right? That there's some other survival advantage of this strain that has kept us sort of, and kept B117 at bay. We are seeing more, P1 from Brazil and B1351 from South Africa as well. I mean, we're also sequencing more, so we're looking more and we're finding, but we are certainly not, because we are such a global and international community, despite even this pandemic, we are seeing some of that as well. So watching very cautiously, but yeah, mostly hypothesis at this point.
Great. Well, thank you for hypothesizing here for us today. I don't see Lakshmi here. I don't know if we can hear her. She's dropped off.
Yeah, she got called to an emergency in the ICU.
Well, that is important. So Michael, maybe you can hold down the fort for us. And I'm curious if you know anything about the post-acute sequelae of COVID in children. I'm a pediatrician myself, and I just noticed the AP News this morning had an article about this. What do you know, if anything? And I did read that the NIH has also started a collaborative to research this. So that's exciting for those of us who care about children, which hopefully is all of us.
I care about children, but I'm not a pediatrician. I think there was recently data on kind of the MIS-C syndrome published. I haven't reviewed it closely, but I think there was a paper in the last month or so more deeply characterizing the epidemiology of this. It might have been out of the CDC. You know, studies of children are included in the NIH call for applications to study post-acute sequelae, and I think many of the efforts will include children, and there will also be unique efforts that are limited to children. One particular notable effort at UCSF, which is actually contributing to a national study, is study of children who did not necessarily have COVID themselves, but were born to mothers who had COVID during their pregnancy. And I think there are a lot of interesting questions with regard to that as well. That's the Priority study, which has a nice website. And so that's like a different kind of subset of children. But yeah, aside from hoping that some of the efforts in children will inform some of the efforts in adults and vice versa, it's not really my area of expertise.
Well, thank you. Back to Erica for this one. We're seeing across the country, we're reading decreased testing, which is a little bit worrying to people trying to monitor where we are in COVID. Are we seeing that in California, or are we still doing pretty well in testing numbers?
We're definitely seeing a decrease in testing, and I started to allude to that. I'd say, our median is still, though, around 300 through 350 per 100,000, so much higher than when we were really struggling early on in the pandemic to test enough people. I think what helps increase some of that is still some of this weekly screening, and I think that's something we're going to be turning to think about is, a combination of where are we seeing pockets of unvaccinated people after we kind of hit, sort of a certain saturation point, and other just high risk settings to really focus on kind of, periodic screening. And then I think, it'll be interesting to see how those capacity bonuses I just presented and how that may play in or not. Although I will acknowledge, I don't know that those are the highest risk persons that are, because we also, of course, are making sure that there's not any kind of requirement for essential services. These are really kind of entertainment or other things like that. So we're keeping a close eye on that. I think the other thing that we're seeing an increased proportion of antigen testing as well. It's up to about 8% of our testing, which we have actually not been reporting. We're about to start putting that data, not in real time, but we'll be putting that up on our site very soon. And I believe the CDC is going to start reporting it as well. And so I think that will play into this as well. And as antigen testing, as we see more reliability and more use of it and more comfort with it, to put that into the equation. So we do, and it's also true that a lot of efforts in the community have been redirected from vaccination to testing. From testing to vaccination, which is important and should be the priority. But I think to your point, we really want to make sure we're not under testing and not getting caught without detecting early. I think there's some other great work happening, thinking about wastewater surveillance and other things when we get down to a much lower level. What are some other ways we can do early detection? So definitely all in the works for sure.
Great, thank you. Sure. I'll go back to you. Any evidence behind what we're seeing as anecdotes that vaccination decreases the post-COVID sequelae symptoms? And if so, thoughts on a possible mechanism?
Yeah, that's a great question and one that has come up a lot. I've heard the anecdotes as well. I've heard them kind of in the news and also, from our study participants sometimes. I've also heard anecdotes going in the other direction, where some people say they feel worse. Those are not in the news. I think, these are all anecdotes and it really needs to be studied. There are some early efforts to try to formally study that. With regard to the mechanism, yeah, you can hypothesize several mechanisms by which vaccination could be helpful. If there is any persistent antigen, even if it is not infectious virus, anywhere, as has been potentially suggested by some early studies. It's possible that vaccination could change or recalibrate the immune response in some way, if that is what is driving the symptoms. These are all just hypothetical, but if we did find that to be the case, I think it would lead us down a clear mechanistic pathway, which would be great.
Great. And speaking of things that we don't entirely understand, but may have some great impact, Lakshmi mentioned that integrative medicine is a part of the care at her post-acute COVID clinic. And I've read, or maybe it was you that told me, that there are several UCSF doctors, Juliette Morgan and Megan Jobson, who are doing some mindfulness work with patients and some breathing. Can you tell us a little bit about that, or if you know anything about that and thoughts on?
Yeah, I don't know specifically about that, aside from being aware that it's going on. A few observations I'd make, though, are that, in the first few months of the pandemic, when everybody was so focused appropriately on acute infection, a lot of patients who were experiencing these issues, felt like they were being ignored or kind of blown off. And I think that the increased focus on this problem has been very validating for people. And so, I don't provide direct clinical care to our study participants, but I'm a clinician. And so I try to be mindful of these things. And I think that the most important thing that clinicians can do when they have somebody coming to them concerned that they have post-acute sequelae of COVID is to recognize that this is a problem that exists. They are not the only person who is experiencing this, and there are major efforts to understand it. And often people are just relieved to hear that. But I think that especially, I think we need to conceive of it in sort of two ways, right? We're trying to understand the mechanism and thinking about all these sophisticated, like, biological interventions that we can do, and that's all well and good if we can figure out the mechanism. But so much of all of medicine is trying to meet people where they're at, understand what they're experiencing, validate their experience, and help them develop, methods by which they can manage symptoms even if they can't eliminate them. And again, for me, it's just anecdotes, but I have found that people who have pursued kind of this integrative medicine approach often feel better, and I think that that's great. And so, we're still working hard to figure out how all of these things intertwine, but I think that those efforts are an important part of the optimal clinic, and will likely become more important over the next year outside of UCSF and around the country.
Yeah, and speaking of meeting patients where they are, this is definitely an area where, and really patient-centered care, this is an area where patient groups really brought this, as you alluded to the forefront. What's your perspective on these patient groups and their impact in the evolution of our knowledge of this syndrome?
Yeah, that's a great question too. So, I come from an HIV research and clinical care background, and have been really grateful for that, because really, in HIV work over the last 40 years now, community advocacy and advocacy, among people at risk for HIV and people with HIV and partners of people with HIV and et cetera, has been so important and has so much driven both the clinical care and the research agenda. And so I think that it's great that that was an important thing from the beginning with COVID, because often, it can take some time for that to develop. I think that those groups have been absolutely critical in, bringing the issue to the attention of the scientific community, and importantly, the NIH and research funders. And so I don't think that we'd be where we're at now in terms of just the massive effort to understand this without those groups. I also think that, I really believe this very strongly, is that it's very important for research projects to have community advisors, and there are efforts at our institution, and I'm sure at many other institutions, to include those voices in this. And that comes in the design of the research questions, but also in making sure that the research efforts reach the communities that are being affected by COVID. And so that, that's really important to us in San Francisco. That's been important, I'm sure Dr. Pan can talk about this from public health perspective with vaccination efforts. So I think all of that translates kind of across the full spectrum of public health, clinical care, and research. And I'm grateful that we have all of those voices.
Wonderful. And this is really the final question, unfortunately, that we have time for, but do you anticipate any guidelines coming out from the CDC? Lakshmi showed us those wonderful the BMJ article, but really said there aren't a lot of guidelines yet. What are you hearing about that?
Yeah, I mean, I am hopeful that, the CDC is clearly engaged and has been very interested in this problem from the beginning. I think that Dr. LIINC, the new CDC director, is terrific, and I actually moderated a discussion with her over the weekend, and she's, she and Dr. Fauci are very interested and engaged in this topic, and I think that it's very promising that there is such a large interest and effort kind of coming from all angles, but especially from above, to try to direct this. So I don't know what to expect, but I sure hope that there can be more guidance, and I think that we would all benefit from kind of an organized, thoughtful care plan that can be implemented for patients experiencing these issues.
Yeah, wonderful. Wonderful. Well, I just am so grateful, Michael and Lakshmi, who's not with us because she's intubating a patient, to you for your clinical work, for your research minds on this, and Dr. Pan, Erica, as always, the work that you do at the state level just benefits us all as Californians and as clinicians. So thank you for your time today. It's been a really wonderful talk and very enlightening. I do want to mention that our next session will be Tuesday, May 11th, and there's more information available at covidroundca.com, and we anticipate that session actually to be on pregnancy and COVID, and we may now include, Michael, some of the work on newborns as well. Additionally, I just do want to mention that CMA provides webinars and resources on the CMA Telehealth Tipping Point project, and you can find the additional information here. Just a reminder, one more time, you'll be sent a survey around 4 o'clock today and can attest to attendance. We'll send out your CMA certificates within a business day. But also just to remember, you can access a recording of this webinar. The slides are actually available for you here as a handout, and those will be available online as well. So if you know of anyone who wants more information on this, you can forward them that information. They can watch it anytime. So thank you to everyone, and we'll see you next month.
All right, thank you. Thanks for having me. Take care.
Mm-hmm.
Bye-bye.